My colleagues sometimes find it very challenging to differentiate between SVT and VT. Do you have any special tips and tricks that you would like to share with us to differentiate between VT and SVT? Of course, so it is going to be quite challenging to differentiate between VT and SVT. But over the next few minutes, let's talk about it. Let's talk about the clinical presentation, the ECG features like the Brugada criteria to differentiate between VT and SVT. So is there anything from the clinical presentation, like the history, physical examination, that can make us thinking about the clinical presentation is very important. The history is important, the physical examination is important. For example, if somebody comes with a palpitation and you do the ECG, which is wide complex tachycardia, but the person is more than 60 years of age with previous history of acute pulmonary infarction, high blood pressure, high cholesterol, that person is more susceptible to have a VT rather than SVT. Okay, so let's talk about the various ECG features that will make you more worried about a VT rather than SVT. Absolutely. So when I look at the ECG, I look at the bigger picture. I try to incorporate the ECG features with the clinical presentation of the patient. Now, in the ECG itself, there are certain features that will make you vulnerable to having VT. For example, if there is an extreme axis deviation, we'll talk about it later. If there is Josephson sign, for example, if there is Brugada sign, for example, then if the QRS complex is very wide, more than 100 millimeter, if there is a fusion bit, capture bit, these are the features which will make me really worried that this is probably a VT. Alright, so let's talk about Brugada criteria that you have mentioned earlier. Tell us, what is Brugada criteria and how do you use it in your clinical practice? Yeah, so Brugada criteria is one of those ECG features of VT. And I use this all the time for differentiating VT from SVT if I see a broad complex tachycardia. This is a stepwise pattern. So the first step is something called the RS wave. So first of all, you look at the lead V1 to V6. If the RS wave is absent, in other words, if there is concordance of the QRS complex, the specificity for VT is 100%. So it's very likely to be VT. So tell us a little bit more about this step one of the Brugada criteria. You mentioned about the RS wave and you also mentioned about concordance. Tell us a little bit more about it. Look, this very first step of the Brugada criteria that is very important. To understand, we need to understand a little basic. If you look at lead V1 to V6, you will see that there is a positive wave, which is the R wave, and a negative wave, which is most of the time S wave, but it can be a Q wave as well. Normally, you will see an R wave and an S wave, a positive wave and a negative wave. If you don't see that pattern, if you see only R wave, which is a positive concordance, or if you see only negative wave, which can be a Q wave or S wave, that is a negative concordance, and if the QRS complex is wide, this is highly likely to be a VT rather than SVT. Thanks for elaborating this step one of the Brugada criteria. So in summary, if somebody has got absence of the RS wave in V1 to V6 or the precordial leads, is highly likely to be VT. In other words, if somebody has got positive concordance or negative concordance in V1 to V6, the specificity for VT is 100%. So until proven otherwise, this is VT. Do you agree? I completely agree with you what you have just said. So if there is positive or negative concordance in V1 to V6, it's highly likely to be VT according to the Brugada criteria. That's such an important feature of the ECG. Thanks for making it so simple and easy to understand in the step 1 of the Brugada criteria. So if someone has got RS wave in V1 to V6, the step 1 is not fulfilled, which means we are going to step 2. So tell us a little bit more about the step 2 of the Brugada criteria. Yes, so the step 2 is also very important. So what you look at is the lead V1 to V6, the precordial leads, and measure the distance between the beginning of the R wave to the nadir of the S wave. This is called the Brugada sign if the RS interval is more than 100 millisecond or 2.5 small squares in a normal type of ECG. So what it means is there is widening of the RS interval. And if the RS interval is more than 100 millisecond, or in other words, if the Brugada sign is present, the specificity for VT is 98%, which means this is highly likely to be VT rather than NSVT. Excellent explanation. Thank you for doing that. So if somebody has got the Brugada sign absent, or in other words, if the RS interval is less than 100 millisecond, we are going to step 3 of the Brugada criteria. So tell us a little bit more about this step 3 of the Brugada criteria and how you will use it in your real life practice. So the step 3 is quite interesting. We call this atrioventricular dissociation. So what it essentially means is that there is no communication between the atria and the ventricles. There is no collaboration, no communication. In other words, you can say that there is some diverge between the atria and the ventricles. This is not a complete heart block. The cardiac impulse is still generated in the SA node as a sinus beat, but the ventricle has got an extra site of origin for some impulse, and that is the monophasic VT or ventricular tachycardia. If you carefully look at the ECG, you will find that there is this white complex tachycardia, very regular, which is the VT, but suddenly there is a sinus beat. This is called the capture beat. So the sinus node is producing cardiac impulse. It is coming through the normal conduction system. That's why it's a narrow complex. Sometimes you might find that the cardiac impulse that is passing from the SA node and the cardiac impulse which is generated in the ventricle, they can fuse together. This is called the fusion beat, which is usually a white QRS complex with a bizarre morphology. So if you find fusion beat, capture beat, that indicates that there is some atrioventricular dissociation. If somebody has got atrioventricular dissociation and the QRS complex is white, the specificity for VT is 98%. So it's very likely to be VT rather than NSVT. This is such an important and interesting finding in the ECG. If you see once, you will never forget it. That's brilliant. Thank you for the explanation of the step 3, which is the atrioventricular dissociation. So if somebody has got atrioventricular dissociation with a white QRS complex tachycardia, there is a 98% chance that this is VT. If the atrioventricular dissociation is absent, we are going for step 4. So please tell us a little bit more about step 4. I understand that step 4 can be quite overwhelming and complicated. Thank you. I think I agree with you that step 4 can be quite overwhelming and quite complicated, and sometimes it can be quite difficult to memorize this. Don't worry about it. You can look it up in the internet or in your textbook. So what I will suggest is, if somebody does not fulfill the step 1, step 2 or step 3 of the Brugada criteria, we look at the lead V1 and V2 and we look at V6, and we look for the right bundle branch pattern or left bundle branch block pattern. If there is a right bundle branch block pattern or left bundle branch block pattern, Then you try to find out what morphology is being fulfilled from the Brugada criteria patterns. I have got quite a few videos on this topic. You can look it up from there, and then you can find out if the person actually is supposed to be VT or SVT. If somebody has got the morphology patterns, there is about 96.5% specificity for VT. However, if the morphology patterns are not fulfilled, then it's highly likely to be SVT with aberrancy. So in summary, we can talk about it that Brugada criteria is a very, very interesting topic to look at, especially when we see those patients with wide complex tachycardia who are sometimes unstable. So it's very important that we look at the Brugada criteria stepwise way, and we can identify, or we can assume that this person has got a VT or an SVT with aberrancy. Thank you very much. That's an excellent explanation. Thank you for going through all the steps of Brugada criteria. In real life, I find Brugada criteria very useful in differentiating VT and SVT. So let's summarize those 4 steps one at a time, and then we will show some examples to our audience. Thank you. Look, I'll be very honest with you. So I cannot remember how many times the Brugada criteria actually helped me in identifying whether there is a VT or SVT with aberrancy in real life. And I have been working for 25 years. So Brugada criteria can be very useful in clinical practice. Let's summarize those 4 steps of Brugada criteria. The very first step is the V1 to V6, looking for the concordance of the QRS complexes. So what it necessarily means is, if there is only a positive deflection like R wave, or a negative deflection like the Q or S wave in V1 to V6, we call this a positive concordance or negative concordance. If that is present, the specificity for VT is 98%. It is very likely to be VT. However, if the concordance is absent, in other words, there is a positive deflection and a negative deflection in V1 to V6, we go for the step 2. The step 2 is the interval between the beginning of the QRS complex and the nadir of the S wave. This RS interval, if more than 100 milliseconds, we call this a Brugada sign. 90% possibility or 90% specificity is VT if the Brugada sign is present. If the Brugada sign is absent, then we go for the step 3, which is atrioventricular dissociation. The atrioventricular dissociation is relatively simple to identify. If you find a fusion beat or capture beat, that indicates that there is atrioventricular dissociation. There is a 98% specificity for VT. If the step 3 criteria is not fulfilled, then you go for the step 4, which is the morphological criteria. Morphological criteria is a little complicated, but I have got a few videos in YouTube for morphological criteria. You can look it up. What it necessarily means is, you look at the precordial leads, V1, V2, and V6, and look for the right bundle branch block morphology or left bundle branch block morphology. There are certain subtle changes that you should look for, and I have explained this in other videos about the morphological patterns. Now, if the morphological patterns are present and the QRS complexes are wide, there is a 96.5% specificity for a VT. However, if that is not fulfilled, if the morphological patterns are absent, then we'll go for the next step, which is probably this is SVT with aberrancy or SVT with bundle branch block. It's that simple. So step 1, step 2, step 3, step 4, and if all these 4 criteria are not fulfilled, we'll think about the SVT with aberrancy. Once again, thank you very much for joining us. It's a great privilege having you here, And we'll have some more videos on this topic and lots of other ECG. I've got about more than 100 videos on ECG. So feel free to navigate through them. And if you have any questions, please drop me a line in the comment section and we will get in touch. Thank you very much for having me, and thank you for taking your time. See you soon. Bye for now. Hey guys, thanks for watching the video. We have got hundreds of ECG videos for your education and entertainment. If you have any questions, please drop us a line and we'll get in touch. ECG is such an interesting topic, and it's a great honor and privilege to help you in learning the ECGs. Thank you once again. I cannot agree more. So ECG is a very, very important part and parcel of our clinical practice. We see this all the time. Some of the ECGs are like crazy ECGs, just weird. Some of them are very interesting. Every patient is different, every ECG is different. So to keep your life simple, we have compiled together lots of ECG materials. Please subscribe to the channel if you have not done already, and press on the like button and share the video with your friends and colleagues. If you have any questions, drop us a line. You can write a comment, and we will bring together lots and lots of more videos for you. And if you have any question, we will very happy to answer those questions. Thank you very much, and thanks for joining us. And we will see you again with a new video, new excitement, and new learning opportunities. Thank you once again. Thank you very much, and thank you everybody. Bye for now. Bye bye.